Statin, bempedoic acid and ezetimibe has made a beautiful love triangle and widely used in lowering the blood cholesterol level. To guide us about this, we have a renowned interventional cardiologist with us, Dr. Shuni Banerjee. And to chair this particular session, I would like to invite Dr. B.P. Pandey, the HOD Cardiology, Narayana Super Specialty Hospital, and Dr. M.L. Bansali, one of the senior most consultant physician, and both of them are founder member of HTS. So please introduce our speaker.
So, Sunip, you're all set?
With your permission, we will start.
Please.
So, thank you, organizer, our Diabetics Society, and respected Dr. Bansali, my friend Dr. Pandey. I have been asked to talk on this three molecule, either in combination or in isolation. The issue is, if I wanted to discuss individually on these three molecule, it will be a whole day, and I am not a lipid specialist to that extent. But as of now, where we stand with the new non-statin therapy along with the conventional statin therapy in 2023, I am going to focus in next 20 slides. So, I'll be happy if you close the door, please. Now, first of all, we have 4 areas to discuss today. What is our target LDL goal? Is it a fixed or it is different in different individual? That is most important. And that we must know, because it cannot be a single shot level. It all depends upon individual risk stratification, and then it comes how we risk stratify, and then I show you a case. Then it comes the issues of adverse event of the drug, all these three what we are use, and a little bit emphasize on bempedoic acid to clear our darkness in mind. So why clear? Because you can remember bempedoic acid's all trial in various subset of population has come with a clear data, clear outcome, clear sanity, many things. Now this is very basic. You may be seen in every meeting how you risk stratify. So my suggestion is to focus on few things. One is, we understand that who are high risk and low risk by knowing the number of risk factor in a asymptomatic individual. So a asymptomatic individual will multiple without any risk factor. The more he is older, he is having risk of cardiovascular disease, and they actually get benefited if you have a high score risk too. Patient with CKD, always at high risk, but cardiovascular risk reduction and therapy benefit estimation is not available. So this is a catch, that if you have some amount of renal jeopardy even, you have to give statin. But the magnitude of lowering of LDL may not translate into a favorable cardiovascular outcome in the future. Similarly, who have a familial hypercholesterolemia, whether heterozygous or homozygous, we know they are at high risk, but the data is limited whether their cardiovascular events comes down or not, because this number of population has been studied less in the science, number is less. All patient with diabetes, you need to decrease the LDL, except some patient who have moderate risk. All are very high risk, and those who have already a cardiovascular disease, his remains on high risk. So practically, for all practical purpose, patients come with a different problem to different physician. A general physician will find patient coming with the abnormal report but no other risk factor. Then he has to take his decision how much he is going to lower. And there maybe if it is 100, okay. So, but a patient who has already suffered a cardiac event or there is a documented coronary artery disease, it's better that rule of 50. You decrease from the baseline if it is high, more than 50% and or less than 55 milligram. And you have to remember this guideline is changing very rapidly. The goal post is becoming narrower. Earlier you thought that 70 to 135 is fine or below 70 is okay. Now we think that below 55 is best. So we need to target a lower LDL and not anything else. With this thing in mind, I just give you a break from the conventional teaching to a patient who is 43-year-old and he has a strong family history of coronary artery disease, but he comes with aches and pains here. Many a time he has been taken antihypertensive drug, diuretic, and hyponatremia was there and he could not tolerate diuretic. Blood pressure is inadequately controlled and aches and pains are there, and fibromyalgia was been diagnosed. He has been given amitriptyline, dothiopain, all these medicines, but still he is not happy and he has stopped statin. And in the meantime, he has presented with some uneasiness, effort intolerance, and a TMT was done which is positive. So this patient with risk factor like hypertension, dyslipidemia and family history of coronary artery disease with a positive TMT is a high risk candidate. And we need actually to give statin. But if he gets fibromyalgia, what you are going to do? So fortunately he has been convinced to get an angiogram done, and where we found multivessel coronary artery stenosis, here we have put a stent, here we are putting a SN with this drug-eluting balloon. So we are not going to discuss on this technical thing, but he comes in the follow-up with 20 milligram 10 milligram rosuvastatin and a ezetimibe only, and this is the result. And he said, sir, now I am happy. So do you think it should be lowered down further or I can stop it? So I convinced him, no, you have to lower down further. And I understand you had issues with statin earlier, you could not tolerate, but now you are, well, no, I am tolerating very well now. So actually many a statin intolerance may be a pseudo intolerance. So we need to interrogate very clearly that is this patient really statin intolerant or not. So what we found that when we combine these three, a 20 milligram rosuvastatin with ezetimibe 10 milligram and bempedoic acid 180 milligram, you can see just less than a 1 year period of time I could achieve a LDL level which is actually recommended by all international societies. So the latest guideline in this year comes in this way, that if you have a patient with acute coronary syndrome, I am focusing now in sick patients, not in day-to-day patients. Again, I told you those are the patients where you have time to decide, you can take others' opinion. But if you have a acute coronary syndrome, start with a high dose statin therapy. Then if you think that the LDL is 55, continue it. And there is no recommendation to escalate the therapy. This is very important. So it's not a blood pressure or blood sugar that a lower is dangerous. See, we have a sprint trial where we have found that if you decrease the blood sugar very rapidly, blood pressure very drastically, in some patients they can be admitted with acute renal failure, dyslipidemia, but the number is less, the benefit is more. But in lipid there is nothing like that. In diabetes also there is a dangerous thing which is called hypoglycemia. So diabetes management, high pressure management is actually more difficult than lipid management, because lipid management doesn't say that you need to decrease your cholesterol medicine if the LDL is below 55. But if your LDL is not in the target, despite on high dose of statin and ezetimibe, you need to add a medicine which is called PCSK9 inhibitor, which is costly actually very much. And this is how you follow up in the OPD. Again, no change of therapy if it is 55, but if it is on the higher side, try to add ezetimibe. Bempedoic acid has not been mentioned here, and PCSK9 is another option. Now the thing is, PCSK9 is costly, may not be all in future, and the problem of not achieving cholesterol to the target level is a real problem, which has been shown in 2017, where only 25% patients with CAD and 20% patient with acute coronary syndrome has achieved a LDL target. And that was in 2017, so they thought that this LDL target may be 70, something like that, or below 100. But when now we think it has to be below 55, it is probably more difficult with the conventional therapy to do it. So what we do? We give ezetimibe, we can do, because we have trial like enhance and improve IT, and average 15 to 20% reduction of LDL has been observed. In bempedoic acid, this clear harmony, wisdom and clear outcome trial we will discuss at the end, actually decreases reduction of LDL by 30% when you combine with ezetimibe, it may be 21%. So probably all the three combination we propose may be better. We propose, and I have shown you the case. So a case doesn't mean that it is a generalizable. So it is a thought-provoking question that all your patients should receive a combination of ezetimibe, bempedoic acid and statin. Now this is one, that if you have a acute coronary syndrome, you must give statin and ezetimibe upfront, and this has been published very recently. A large number of patients, some are on rosuvastatin and some are on rosuvastatin plus ezetimibe, and what has been found over a period of time, 1 year, 2 years, 3 years down the line, the mortality who has been taking a high dose statin along with ezetimibe, they do actually better so far as cardiovascular all cause mortality is concerned. The same thing applies for patient who has underwent coronary intervention, small dose statin, intermediate dose statin. So small dose statin had with a ezetimibe combination, the number is only 10,000, but majority other received a intermediate dose of statin, that is 20 milligram. And what we found, that high dose statin therapy and combined lipid-lowering therapy actually is this. So combination had a lower occurrence of primary endpoint, and the discontinuation of statin and lower new onset diabetes over there. So then the important question comes, is statin a diabetes producing drug like thiazide? It is not so easy to conclude, but I will show you some recent trial, and this trial is again comes in everybody's mind that when you wanted to choose two of this giant, Mohun Bagan East Bengal, whom to support, atorvastatin or rosuvastatin. And Korea people have done a very beautiful job, this Lodestar trial, where they have given all these eligible high risk patients a combination, either a atorvastatin or a rosuvastatin. So the take home message is very clear, and that should clear our all darkness. The study is the first to randomize rosuvastatin with atorvastatin in patient with documented coronary artery disease. 3 years composite all cause death, MI, stroke and coronary revascularization did not differ. Rosuvastatin treatment was associated with lower LDL cholesterol, but it is also carried with high risk of new onset diabetes requiring anti-diabetic medicine and cataract operation. So this is a observation, whether we accept it or not, that's the matter of debate. And my last few slides is on this new molecule, the bempedoic acid. What we have found, ezetimibe in combination with statin in acute coronary syndrome is beneficial over a period of time. Does bempedoic acid has this thing? Because bempedoic acid came initially with patients who are not tolerating statin intolerant patients, and bempedoic acid's action on the skeletal muscle is nil. So we thought that this will be the answer for them. But when the further study was being done, it has been shown that bempedoic acid actually decreases not only LDL cholesterol but also high sensitivity CRP. So why high sensitivity CRP? Because we think acute coronary event is an inflammatory problem, so lowering of CRP is actually a better choice. And a decade back there was a similar study called Jupiter study was done, where rosuvastatin was used, and they found also taking rosuvastatin in intermediate risk category patients also decreases the CRP. So decrease in CRP has a logic, probably it can diminish the future outcome. And this outcome trial has been published recently, which is called a clear outcome trial, and which shows that if the patient who are at high risk of ASCVD with true statin intolerance, fasting LDL more than 100, and they are taking either placebo or bempedoic acid, no statin, remember, the primary outcome of composite death, MI, stroke is significantly less. But this is probably the cases which are having multiple risk factor, but they didn't have an event. But if they had an event, probably this mortality would have been much better or higher, and we have to wait for few more years to get a data on these patients. But now onwards you have patient who really can't take statin, you can give this and then re-add statin in small dose as challenge with a better compliance. So to end, we have to find out the side effect of this newer drug. They are not absolutely side effect free. So ezetimibe sometimes usually well tolerated, rare occasions of liver enzyme elevation. So if you have more than 2 or 3 times, consult a hepatologist. But otherwise, bempedoic acid has only one issue, that it can produce gout, and there are some evidence of spontaneous tendon rupture in the study, but I have not found any such cases. So I end here. and maybe this is a long topic. I try to focus on the newer things rather than discussing on other issues. Thank you, chairpersons and audience.
Thank you, Dr. Sunip Banerjee, for insight into lipid lowering therapy, that is statin, bempedoic acid, and ezetimibe. So, in acute coronary syndrome, which combination will you prefer? Statin with ezetimibe or statin with bempedoic acid? Because statin and bempedoic acid, they are both acting on same pathway, and ezetimibe and statin, they act on different pathways. So which will be your drug of choice combination?
I think what we do in practical in acute coronary syndrome, the high dose statin, depending upon the patient's body weight and approach or attitude, at least a 40 milligram rosuvastatin or 80 milligram atorvastatin. Now, we should not deviate from this concept that we should strive with this statin, high dose, just at the beginning, and take at 4 to 6 weeks time what is the status. Now, if the patient is already taking statin and then he received this, then a combination of both is available. I think we should add it to aim further down. What I have not mentioned or highlighted, the most potent LDL lowering drug is the PCSK9 inhibitor. So we are giving sometimes who have a history of uncontrolled dyslipidemia, questionable compliance with the medicine, and try to initiate this injection in hospital and continue depending upon this future LDL level. That is how I think we are going. So in a statin NAP patient, I think I am not using ezetimibe bempedoic acid at the beginning. I try to give or high dose statin itself. Yeah, this is, they are saying, yes, lowering the better. But still, practically I tell you, if he has not taken anything, high dose statin with ezetimibe combination is usually not available. Now it is available 20 plus 10 or 40 plus, but if I can give 80 atorvastatin, why not?
Sunip, at least the Lipid Association guideline tells us one has to use high dose statin and ezetimibe in acute coronary syndrome.
Yes.
In a similar line with European. Yes, Anirban. Yep.
Srinivda, just one question, that you have already showed that the statin in a, say, primary care setting, in primary prevention, statin versus statin plus ezetimibe. So statin plus ezetimibe is a better option than statin only. So you have showed. Just I am wondering whether any study available which showed that whether statin versus statin plus ezetimibe versus statin plus ezetimibe or bempedoic plus bempedoic acid, 3 drug will be better than 1 drug or 2 drugs. So triple combination, whether is additively better compared to statin plus ezetimibe.
We are hypothesizing that,
Yeah.
but we don't have a trial.
We don't have any
Since
trial.
clear outcome data is not so clear, at least from a clinical endpoint.
Absolutely.
So I think this is not the right time to talk about bempedoic acid. So for secondary prevention, I think ACS is a guideline mandated. Use ezetimibe. Later on, you can de-escalate. Regarding the new onset diabetes, I think we should not be worried about. We should not be. Because whatever 9%, it all depends on how intensely you are.
Absolutely.
If you are intermediate, moderate, it is not there at all. And with the guideline now mandating the use of colchicine as a new antiplatelet, anti-inflammatory, which reduces the diabetes. So it will act as an antidote for statin induced. So I'll end it here. We are running short of time.
Yeah.
Thank you, Sunip. It's my pleasure, duty to honor
Felicity,
you.
sir.
He's my classmate.